All right, well, I'll just jump into it. So, my name is Jamaal Tarpeh. I'm one of the first year occupational medicine residents, and my study is comparing antidepressant therapy to running therapy on the effects, or comparing the effects of both of these treatment arms, depression. So, I found this study through a PubMed search, and the reason I chose it is twofold. One reason is in clinic, we often screen a lot of workers for mental health issues. And depending on their level of distress, exercise is a prescription or something we recommend to treat, anxiety or depression. And then the other reason is it just had a study design that I thought was interesting and hadn't seen before. And we'll kind of go into details about that study design. So, the purpose of this study, so the essential research question was how do antidepressant medications and running therapy compare in their effects on mental and physical health in patients with depression and anxiety disorders? And so, some basic background for this study. So, for people with depressive or anxiety disorders, antidepressants and psychotherapy, such as CBT or cognitive behavioral therapy, are generally considered first line treatment options. Specifically for antidepressants, they can, even though they can be moderately effective on a personal or a clinical level, they can still sort of have variability in their effectiveness. And for some patients, they can have intolerable side effects. Some of those side effects can be gastrointestinal symptoms, sexual dysfunction, insomnia, things like that. So exercise therapy essentially represents an alternative option that comes with less side effects and potentially lower cost. Um, there have been studies comparing antidepressants and exercise therapy, and generally the studies have shown them to be equally effective, though most of these studies are moderate in quality and kind of these supportive, consistent studies, but there's a dearth of sort of high quality studies really comparing these two to each other. So in our field, the American College of Occupational and Environmental Medicine, according to our guidelines, for major depressive disorder, exercise is given a grade C recommendation. And then for anxiety disorders, it's given a grade B recommendation. So in this particular study, there's a few objectives. Essentially, they looked at the effects of these two treatment arms on mental health remission rates, reduction in symptom severity, and physical health outcomes, comparing aerobic exercise to antidepressants. So getting into some of the basic methodology. So the type of study here is a partially randomized patient preference design. What that means is, so you have two treatment arms. You have the aerobic exercise arm, or the people that are doing the running therapy, and then you have the antidepressant groups, the antidepressant group. And the original intention was to randomize people between these two arms. But if people didn't want to be randomized, they allowed them to choose what treatment arm they wanted to be in, whether they wanted to take antidepressants or whether they wanted to exercise. To go into a little bit more detail on those exposure arms. So for the antidepressant group, they generally treated them with standard antidepressants. So escitalopram, also known as Lexapro, was the first default option. And then if there were issues with efficacy or tolerability with that medication, patients were allowed to shift over to sertraline, which is also known as Zoloft. And so in the running therapy group, the idea was is that it was supervised. Ideally, people ran two or more times per week, and patients were they wore heart rate monitors, and the idea was to keep them in a specific reference range of heart rate intensity based on prior studies that the authors had um, used for this study to determine that that specific heart rate range provided clinical benefit. And so the follow-up period for this study was 16 weeks. If some patients, for whatever reason, couldn't do the supervised therapy, they were allowed to do running therapy at home, but that was unsupervised. So a little bit more detail about the study population. So so this study was conducted in the Netherlands, and they recruited patients at a specific mental health clinic, and they had originally started with about 240 patients. Due to various exclusions, that dropped down to about 141 adults who were diagnosed with either major depressive disorder or some type of anxiety disorder, social anxiety disorder, generalized anxiety disorder, agoraphobia, things like that. As far as the inclusion criteria, um, patients who had a confirmed depression or anxiety disorder based on DSM-4 criteria, and there was a specific scale or questionnaire that they used to establish that diagnosis, and then patients between the ages of 18 to 70. And then exclusion criteria was recent antidepressant use, regular exercise, severe psychiatric conditions, or active suicidal risk and medical contraindications, like somebody with severe heart disease. And so this is essentially their workflow. And so you can see, 141 patients were included in the study. And most of the patients were either randomized, or if they didn't want to be randomized, they chose what treatment arm they wanted to be in. And then after that, a few more patients dropped out after that. But there was shown to be no statistically significant difference between dropout rates between both treatment arms, between aerobic therapy and antidepressant therapy. So to go a little bit more into the outcomes. As far as mental health, there were two major outcomes that they looked at. So remission at 16 weeks. And so the questionnaire they used was a specific questionnaire. I think it's called the Composite International Diagnostic Interview, which is a specific type of questionnaire that allows you don't necessarily have to be an expert in psychiatry or psychiatric diseases to administer this questionnaire. So at the beginning of the study period at week 0, people took this questionnaire to confirm that they had a DSM-4 based diagnosis of depression or anxiety. And so remission at 16 weeks was defined as no longer meeting criteria for the current disorder. They could still have symptomatology, but if they weren't meeting the criteria for DSM-4, that was counted as remission. And then symptom severity. So for depression, the inventory of depressive symptoms questionnaire was used. This is a self-reporting measure. For anxiety, the Beck anxiety inventory was used to measure of symptom severity, and then symptom severity reduction of at least 50% was counted as that was the case definition they used for symptom severity reduction. And then for physical health outcomes, they used a variety of different measures or surrogate endpoints. So you can see the cardiovascular metrics here, metabolic indicators, fitness indicators. There were some immunologic indicators also, like CRP levels, and things like that, that were used also. So statistical analysis approach, they did an intention to treat analysis on all assigned participants. Um, and then they also did a per protocol analysis for people that did complete the treatment arms for either aerobic therapy or antidepressant therapy. They did an ANCOVA analysis, which in simple terms is it's like combining linear regression with ANOVA, ultimately to adjust for any covariates at the beginning of the study period that may serve as confounding variables. And when we look at the descriptive statistics, there was one particular covariate that was statistically significant difference between both groups. And then within group differences, when they were looking at severity reduction, they used a paired t-test. So this is the chart just looking at some baseline characteristics that were measured at week 0 or the beginning of the study. Highlighted, the main thing you can see here is that between the running group and the antidepressant group, there was a statistically significant difference in depressive severity symptoms based on the self-reported scale at the start of the study. There was a higher severity in the antidepressant group compared to the running group. But otherwise, there were no statistically significant differences in the covariates that they um, measured in the study outside of that one. So getting into the results, so looking at the mental health outcomes, essentially they found no significant difference in remission rates between both treatment arms, either aerobic therapy or antidepressant therapy. And then as far as symptom reduction, there were similar reductions in both depressive symptoms and anxiety. But for anxiety symptom reduction, they did find that there was a faster reduction at week 6 in the antidepressant groups. But when you track it out over the whole study period, there was no overall difference. So basically saying that aerobic therapy and antidepressants were equally effective in treating the mental health outcomes measured in this study. And so they looked at a variety of physical health outcomes. I just recorded the ones here that were found to be statistically significant. So basically, running therapy outperformed antidepressants in these physical health measures. This was largely due to two reasons that they report, due to the reductions due to aerobic therapy, but also deterioration from antidepressants. So, for example, like antidepressants increasing people's weight or weight circumference or things like that. So, this is just a visual representation of the data comparing the reduction in symptom severity between the two treatment arms, both for depression and anxiety, ultimately showing that there was no difference, statistically significant difference at week 16 between both treatment arms. So this is just more visual data for the same conclusions. Physical health outcomes, just to reiterate, ultimately running therapy was found to be more beneficial on physical health outcomes compared to antidepressant therapies. So the summary, ultimately, the big picture here was that antidepressant therapy and running therapy were found to be equally effective on treating depression and or anxiety. But when it came to physical health outcomes, running therapy outperformed antidepressants, largely due to improvements in physical health outcomes from running, but deterioration in the antidepressant group. And so at the end, the authors essentially conclude that exercise therapy is a valuable option in mental health care and both addressing mental and physical health and should be considered standard practice for those with depression and or anxiety disorders. Kind of go into some of the strengths and limitations of this study. So some of the strengths. So the study design, thought it was an interesting study design. In some sense, you could argue it's a pragmatic study design, and it sounds like, or my what I gathered from the study is that the choice of this study design is largely to sort of reflect sort of real world of how people choose their treatments and the motivations they have behind choosing specific treatment arms. And in psychiatry where randomized control trials are often hard to conduct with blinding or things like that, the patient preference design can sometimes be beneficial, but we'll also talk about why I think it's a major limitation to this study. There was a comprehensive assessment of outcome variables, especially on physical health. It's hard to have a specific case definition of physical health, but they used a variety of surrogate, endpoints that they could to the best, or at least to the best that they could, knowing you could always use more, you could question some of them. Um, but I'll also kind of talk about why I think there's a little bit of a limitation there too. I thought they had clear case definitions um, in this study. As I mentioned before, they had a variety of surrogate endpoints. I thought the statistical methods were appropriate in this study. Given the state of the evidence of looking at the impacts of exercise therapy on depression, this is a clinically relevant study. And if you're just kind of looking for whether there is any effect, I thought 16 weeks is an appropriate follow-up period, given how much time you generally need to give to even see any sort of beneficial effect from antidepressant therapy. So You could argue that's not long enough for long-term effects, especially when you're talking about how some of these surrogate endpoints actually track to clinically sort of relevant outcomes like, coronary artery disease or things that, we actually care about down the road. But I think in the short term, it was an appropriate follow-up period. However, the weaknesses of the study, and I think this is the, ultimate weakness with the study design is, if you're allowing people to choose their treatment arms, you're essentially introducing a type of selection bias into the study. And for me, that sort of hampers the internal validity of the study. Um, and it calls into question how much you can, actually trust the results, because now you're introducing unmeasured confounders that may be associated with people's preferences or motivations for choosing a specific treatment arm. And without addressing those, you can't really know what the true treatment effect is, at least in this particular study. And then you add the fact that you're using a self-reported, symptom scale, both for depression and anxiety. So, you have people who are motivated to choose a specific treatment arm, like exercise. And then those people might have certain expectations about what they think exercise can do for them. And that may also play into how they're filling out these sort of self-reported scales. So, I thought that was sort of compounding, the issues with this study. In the discussions, they kind of talk about how they try to address this issue by including this inclusion type by treatment interaction term in their ANCOVA model. But for me, the efficacy of that statistical technique was unclear, given that around, I think only about 15% of the study population actually opted to be randomized. So the majority of people chose their treatment arm. And so there may not even be enough power in the group of people who allowed themselves to be randomized to sort of try to find an effect there. So I don't know if that was an effective technique, even though, they tried to correct for that issue. Um, and this is the last one, I guess, is less a weakness of the study, but just more clinically relevant, and that there was lower adherence to running therapy compared to antidepressants. So I think even if these study methods were better, there would be barriers to sort of implementing this with patients in clinic if there is a, difficulty in getting people to adhere to running therapy or a rigorous running therapy program. So the big picture here, so I think this single study, at least for me, is sort of invalidated by the intrinsic study design. However, in the grand scheme of things, there is likely a valid association between the impact of exercise on depression and anxiety, given the current grade that it has for that association. And there's a number of sort of consistent supportive studies showing this effect or showing this association. However, there is a dearth of sort of high quality studies really showing what that effect size is or whether um, running therapy is superior to antidepressants or things like that. So I think because of that, there is still value in recommending running therapy or aerobic exercise for addressing mental health, but you would just have to sort of kind of have a um, be cautious in how you sort of interpret these studies or how much sort of faith you put into the effect size. So these are some discussion questions, I just sort of came up with. So, if anybody thinks, do any of you guys have any other biases or limitations that you think I didn't address here that you think could also affect the results? Yeah.
Studying both antidepressants combined with physical exercise, did they consider doing that?
Um, yeah, they didn't talk about that in this study, but there are studies out there that look at a combined effect between exercise and antidepressants, and they do show benefit. But once again, there's sort of there's consistency across studies, but sort of the effect is still something, under active investigation.
I think it's the definition of what exercise is or aerobic exercise, right? Because in Amsterdam, I don't know many people that drive cars. Everyone races around Tour de France style on all their bikes. So racing to the study, the people taking antidepressants were probably exercising, so it's
Yeah,
something that I thought of.
that's a good thought. Good thought. Oh yeah, go ahead.
Curious, did the article mention why they use DSM-4 instead of 5?
Yeah, set of DSM-5. Yeah.
Yeah, I'm just
Um,
he like using the old. I mean, I don't think it really affects the definition for
I-
depression or anxiety.
yeah. So
But it's just curious, like why they use the older like
they
diagnostic criteria.
they didn't. I had the same question. I just doing a little digging, and I could be wrong here, but I don't know if there's enough of a difference between DSM-4 and DSM-5 when it comes to diagnosing major depressive disorder or any of these anxiety disorders. So why they did that, I don't know, but I don't think it has any bearing on the study here.
Just so people know, DSM-4, I think, was 1994, and DSM-5 is 2013. And we're like in 2023
Yeah.
here.
It's kind of odd.
So
It was
that's-
like
that's why they said
2022, so yeah, it's like 10 years later.
It makes you wonder how old is the data? So they,
True.
I was just looking in the methods and to the beginning of the methods where they usually would say, or they could, sometimes say, this came from this data source or collected at this time point or whatever. And oftentimes journals will require you to disclose the dates, the window in which you had collected the data, because stuff happens in the
Mhm.
world that could affect that as well as, where you got it and that sort of thing. So the absence of that.
Yeah.
And the use of the DSM-4 would suggest to me this could be really old data
Maybe. Yeah.
that they just are now getting around to publishing.
Yeah.
Right. That happens. People, sit on papers that have been around, they have file drawer papers that they didn't publish and they're like, oh, I could dig this back up. And so if they can get away with not disclosing how old the data is, you kind of have to keep an eye out for markers to indicate, okay, oh, this is older data. Not that old data is bad. I mean, we can
Yeah.
still draw meaningful conclusions, but if the criteria we use to diagnose a disease has changed because of knowledge and things that have happened since then it makes it a little precarious to draw conclusions from it. So
Yeah.
I'm guessing it's old data, but I could be wrong.
Possibly.
View this study as high, medium, or low quality.
I would put it in the low quality category, at least for me. Partially just because I think the study design, I think the whole point of, especially if you're looking for a treatment effect, randomization is sort of a cornerstone of these kind of study designs. And so it's kind of counterproductive, I think, to allow people to choose their, treatment arm. You're introducing all kind of confounders into the study. So and that's kind of the reason, I chose the study. I just hadn't seen that study design before. I've seen some people say it's used in, psychiatry or psychological studies, but I think that also ultimately renders it a low quality study design or low quality study.
Very good. I agree with that. And actually, when I tried to score it with the ACON criteria, I ended up with a 2, which is
Yeah.
dead ringer for low quality. And there's the important thing is you've actually got moderate quality evidence, not, of one study is actually showing superiority of exercise to antidepressant. Another one shows equivalence. These are randomized trials.
Yeah.
And those are based on when we published the depression guideline in 2018. There may be further studies since that time. But anyway, the point being that this study isn't going to overturn the existing evidence base.
Yeah.
It's good to still present this.
Yeah.
You chose an article of a different study design.
Yeah. I think if you're going to argue for the association, this isn't going to be the evidence that supports that.
Jamaal, regarding the two groups, one had 45, one had 90, 96.
Oh.
Do you have any thoughts on the imbalance there and what might have driven that?
Yeah. I think it, kind of goes back to that, the study design and maybe that the patient preference design. I think that's another limitation of the study is the imbalance between both treatment arms. Maybe more people, have sort of preconceptions about antidepressants or, prefer to exercise over taking antidepressants. So there's, a number of different reasons, but I think those are all confounders that were, introduced into the study.
So I was a little surprised. I guess I have to think about it a little bit more, but taking an antidepressant is certainly a lot less work than going on a treadmill. So I would figure the numbers
You would
might
think
be
the other
flipped,
is, yeah.
but it was voluntary participation, of course.
Yeah. And that's the problem is
Education.
what would that have looked like? Um,
In America, you mean?
yeah, well, that's one thing, yeah. Um, but yeah, by the fact that you're allowing people to choose, maybe those people just have higher motivation for whatever reason, and that kind of leads to that imbalance. So it's not really reflective of,
Well, antidepressants also have some pretty meaningful side effects.
yeah, and side
Right?
effects.
I mean, that's the other thing. I think I think if most people were given all the information, you'd be surprised at how many
Yeah.
of you. Well, I'm gonna try running at least at first.
But
There's all kind of-
my time in Amsterdam, everyone's on a bike, so it's not a big deal.
Yeah.
Yeah, and there's all kind of preconceptions that people have about pharmaceuticals, and like you said, the side effect profile is a big thing.
Along
So
those lines, like they don't even talk about like the number of people that like, oh, the first medication didn't work, so we changed them to the cetirulline at all. Like,
Yeah.
it doesn't pop up anywhere in the paper.
yeah, exactly.
That's a really important point. And how fast does exercise work and how fast does an antidepressant work?
Yeah.
Which one works faster?
I mean, antidepressants can take weeks before
Yep.
you start to see treatment
That's the
effects.
problem.
So
I mean, if you had a relative who was depressed, that's a really important thing. Like especially if they're not doing anything.
So it gets to that, is 16 weeks long enough, right? I mean, it probably is.
Yeah.
But it would have been stronger, like you mentioned, to go longer than that.
yeah, exactly.
Also, they did not talk about cognitive behavioral therapy, which is also like the first line for depression.
Yeah,
So if
Yep.
you could put that in with the people classes, so it would have been nice to see how would that impact depression on that scale.
yeah, I agree with you. I agree.
Ask the participants if they are receiving cognitive behavioral therapy.
Yeah.
Or other.
Yeah.
That's the
Or any
problem
other
with
thing.
the co-interventions are
Things
not,
on the railroad.
it's another knock on.
Yeah.
Or if they run indoors or on a treadmill. Right, outdoors on a floor.
Right, they're receiving.
Because then you got sun exposure and other things that.
Any other questions? And this is my Chat GPT picture. So awesome. Yeah.
Get that mic. And then turn it on once you got it. Then you can go on whatever you want.
So my name is Jake Cornwell. I'm a first-year IH student. My topic of discussion today is a comparison of consumer-grade electronic radon monitors. One of the reasons why I selected this was I used to function as an EHS for local health departments, and we did residential residential radon monitoring for these volunteer residents. So something that I'm familiar with, and then I'm hoping to do some more research on it as part of my thesis. So this was published in the Journal of Radiological Protection. The study itself was conducted in Ontario, Canada. So we'll talk a little bit about the relevance of that. So why radon? Why is it a concern? So if you're unacquainted with radon, radon is a colorless, odorless, radioactive gas that's endemic in almost all of North America. So whether you are in Florida or here in the near the Rockies, the concentrations obviously vary, but there's substantial amounts of radon in our community. So it affects everyone from children to adults, one of the most concerning things about radon is its classification as a carcinogen. So it's a class 1 carcinogen. It is the leading cause of lung cancer among non-smokers. So it has cumulative effects that are very problematic for every community that this gas is endemic in. So yeah. So I didn't know where to plug this in. Everyone always does the cool AI things. So I gave it a couple of different prompts. I asked if it could generate a residential radon sampling system. So if you're unfamiliar with radon sampling, there's long-term and short-term monitors. These don't look like either of those. So it's cool. I like it, right? Like they're probably look more like Geiger counters or something analogous to that. I also gave it the prompt to conceptualize or visualize radon gas, how it would look in a residential setting. Once again, it's a clear or colorless, odorless gas. So that doesn't really vibe either. And then finally, last little prompt I gave it was, what do you think the exposure would look like? And that's what it kind of popped out. I guess AI took up vaping or something. So yeah, I missed one. I meant to include a little map up here, but as I said earlier, radon is endemic across the entire all of North America. Gratefully and thankfully, most of its most dense areas of concentration aren't in urban or population dense environments. There are obviously exceptions to that rule, but onward to the goal of this investigation. So with this investigation, Canadian researchers wanted to determine if they could find or determine a consumer grade radon monitor that would allow Canadians or individuals of any nationality to use and determine exposure in residential applications. So the main goals are to evaluate the accuracy and precision of these radon monitors in a consumer grade. So basically where somebody could just buy them maybe in this application. This study's now 5 years old, but maybe you buy it off of Amazon. Compare different monitor models under controlled conditions. So this is not a residential test or study. This was done in controlled, calibrated chambers. Determine how reliable the monitors were for informing homeowners about radon levels. This is something that was probably the greatest success of this overall study. And then assess whether the readings could be used to make mitigation decisions. So if you're unfamiliar with radon mitigation systems are very expensive. They're more of a commonplace or a more common practice to install in new builds. But if you live in any home that's pre-1980s, it wasn't even a factor to consider when you built your home. So tens of thousands of dollars in many applications to install a mitigation system, while that might not always be necessary. So the study, the design, was an experimental lab-based study with some comparative analysis that occurred after the results were determined. The design specifically tests consumer-grade radon monitors in controlled conditions. The Canadian National Radon Proficiency Program was how the radon monitors were selected, as well as where the actual testing took place. So, oh goodness, I must have sent I messed up real bad, guys. I sent the wrong slides in, so my apologies. So I don't know if there's any correcting that. I could but
If you're quick, you might be
Yeah,
able to, but.
we'll just call it. There shouldn't be too many other issues, but that's a little flub on my part. Sent the wrong slides. So the overview of the methods. So with this Canadian National Research group, they determined that they wanted to compare consumer grade monitors versus a professional grade monitor. And they determined that they were going to use 6 different monitors. They purchased 3 of each monitors and they ran them across 4 diagnostic tests. So with these tests, they ran the monitors at 200 becquerels. So the equivalent for here in the US, 200 becquerels is approximately 5.4 picocuries. So with that, the EPA threshold for actionable limit of radon in a home is 4 picocuries. So this is somewhere in the ballpark of like 35% higher for Canadian regulatory agencies. But with these different thresholds, like I mentioned before, becquerels are their unit measure of choice, and they ran 3 tests at 3 different levels, and then 1 test was run simulating the winter conditions and then summer conditions. So, like I said earlier, this was based in Ontario, Canada. The overall conditions in wintertime situations, the weather is significantly colder, so everyone shelters inside or stays inside more or significantly more when they are in those winter months. So that was of particular concern to me because we're in this situation where 400 becquerels and 1,000 becquerels translates to a pretty significant dose that wouldn't be really observable in a residential setting. So 1,000 becquerels ramps us up to 370 picocuries per liter, and then 400 was 10.81 picocuries per liter. So the real focus of my discussion was on this 200 becquerel marker. They also controlled for a couple of different factors such as humidity and temperature. So for the winter months, they did it at 18 degrees C. And then for the summer months, they did it at 30 degrees C. So obviously that was targeted for a bunch of different reasons, as we'll talk about. But performance evaluation. So as I said before, they're looking for accuracy, making sure that these monitors both report an accurate or a specific concentration of radon that's being monitored or measured. And then precision, they wanted to make sure that their groupings, their data was relevant to a consistency of measurement. And then the overall measurement factor, they compiled both the accuracy and the precision, and then they assigned it a grade. So an A grade was between equal to or less than 10% error when compared against the professional model. And then B was 10 to 20%. C was 20 to 30%. And as a form of, or as a reference, professional models have a 20% error ratio. So if they're considered within professional tolerances if they have 20% or less error. So, oh my gosh, I butchered this, guys. That's such a flub. Can I just plug my laptop into this?
You can try.
Yeah.
I don't myself with any IT related concerns.
How about now?
Got it. Thanks, guys.
I'm so sorry. Ugh. Okay, well, let me get back to where I was. So I believe I already discussed the reason why they used a high precision AlphaGuard DF2000. There was no rationale on why they used this particular model. Not that it's a good or a bad model. Wasn't able to dive into that too deeply, but so the materials that they used these 6 different models. 3 were battery operated, 3 were corded. So I use that as one of those discussion topics as we'll hit if I can get it pretty quick. 2 of them were provided with a calibration certificate. So the other 4 were not. That doesn't mean that they weren't calibrated prior to leaving factory, but they didn't come with that certificate. So once again, the reason or the methodology that they chose was these were commercially available options through the Canadian National Radon Proficiency Program. So Canadians can actually rent these devices to test their own homes. Jumping into it, the results. One of the things that's really problematic about the actual results was that the majority of the monitors improved performance once they passed that 200 becquerel per cubic meter threshold. So as I said earlier, there is a concentration in which there's this actionable limit where we're talking about pursuing mitigation. Most of them had lots of errors and tendencies to report less than accurate or precise measurements. So some monitors were affected by environmental conditions. So they did better in summer conditions with more humidity and higher temperatures than they did in winter conditions, which are lower temperature and lower humidity. This was the first round, and this is the one that I focused most of my attention on for this discussion. So we see the first 2 columns over here on the left, the safety siren and the procortium. These were some of the best performing monitors, as I'll reference in the next slide. But there was significant variation in accuracy and precision in the other models, with 2 of the models used having reporting higher than what the chamber was actually pressurized with radon concentrations. So it was actually significantly higher, which, as I allude back to that conversation, if you're testing your home for radon concentration and the monitors are telling you that you have a higher than average concentration, you might be pursuing the mitigation steps, which is really costly and not necessary in this application with monitors that aren't providing accurate data. Continuing on, so I mentioned that there's A, B, C, and D grades. So there wasn't any Ds given in this study, but there was significant variation across the monitors. So I'll draw your attention to the safety siren and the air things. So this first column right here is the round 1. So this one was summer conditions. So they both, in the summer and the winter conditions, both of them received A or B grades. In the radon world, most of the time when you're doing radon sampling or monitoring, you're in a condition where you want the envelope, the home, to be closed. And so with this test, if you're getting results that are less than accurate or the reliability of the monitor is less than ideal, you could be putting yourself and others in an odd position with the results not being accurate for the season in which you're doing these tests. Continuing on, I'm focusing once again primarily on this 200 becquerel monitoring limit, as that's the action limit for mitigation. We see down here at the bottom that we had ranges in accuracy and precision from 1% to 24%, and then from 2% to 15%. So a pretty wide gap in the overall measurement error for this study. This was across multiple different monitors, but I've already kind of highlighted the monitors that did or that were the most successful in this study. Now the control itself down here at the bottom, it was measuring at 206 plus or minus 28 becquerels for the first round, and then for the second round it was 208 plus or minus 28 becquerels. So this was used as the reference guide for when these calculations were done. So that's what was used there. Now, I'm wasted a whole bunch of time, and my apologies again. The strength of the study, they definitely used a well-regarded radon monitor device as a reference. So with that, they did their homework. They made sure that the devices that they were going to use would be that would be a good point of reference for them. The indoor winter and summer months, this is all about applicability in the study. And so if these devices aren't suitable for the environments in which they're used, they're not going to be really applicable. This study won't be applicable for those that need it. And considering both accuracy and precision, this study was fairly comprehensive in monitors that you would want to use versus those that you would not want to use. Now, there were some limiting factors. It's a pretty limited sample. There's quite a range of monitors that we could use. So there were lots of areas for potential inconsistencies that could have been mitigated by larger sample sizes. The sampling period was only 7 days. So this would provide us with a short-term sample, which the gold standard is, or the ideal monitoring or sampling is done long-term, so 90 or more days, as mentioned in that short testing. And then lack of real-world home conditions. So this was done in a controlled environment. Anybody that has a home knows that there's heaters that are always kicking on and off in the summer. You have windows that are open, things that get left open, whether it's the doors or the windows. You have building envelopes that aren't reliable, so you can have damages in the structure which allow lots of airflow to occur, so you don't get the accumulation and the concentration of radon gases. So this was only a study that studied the effectiveness of the monitors themselves. As the authors identified, there needed to be more investigation in application to residential environments. Now, I came up with a couple of discussions. I'm already kind of over time. With these different questions, I don't know if anybody wanted to bring any up. Environmental factors are always going to alter, particularly consumer devices. Professional devices are made to higher standards, so circuitry, containment, all of these are factors that lead to more reliable results in professional grade equipment. And then environmental testing chambers used in this, they don't reflect real world environments. Their relative humidity was at 50 to 70. If you look at where they did this in Toronto, Ontario, they're right next to the Great Lakes. Humidity is much higher. It can skew these devices pretty significantly. Measurements in consumer grade monitors compared to those in professional. So as I said earlier, professional grade is 20%. Most of these pieces of equipment received A's, B's, and C's. So C's had a 30% error. The majority of them had only A's and B's. So in terms of comparison with professional grade monitors versus consumer grade monitors, they handled or they were right on par with each other. professional grade monitors are going to have longer or more longevity in terms of the cycles of use, duration of use, as well as can withstand calibration. So, is there a question?
Do you know if the values of 200, 400, 1000, do they correlate to any health effect, or why do they choose them if we know that the 4 picocuries is the cutoff value?
So the reason why they chose 200, 400, and 1000 was their environmental chambers could go from 150 becquerels up to 500,000, if I remember correctly from the reading. They wanted to be able to just determine the realistic observations that could occur on the extreme scale. So theoretically, you can get up to 1,000 becquerels, pardon, but it's not commonly seen. It's only in like very tightly sealed envelopes that don't have outside air intake or they're opening doors and windows. So it was, short answer is it's kind of arbitrary. But
You wanna, I don't know if you know, but do you wanna mention the issue of basement level versus other levels in the house for people because they may not know?
No, of course. Thank you. So as you could assume, most radioactive elements are heavier than standard like metal or other types of elements. Radioactive elements are heavy. Radon is the same in the same situation or family. So it has this tendency to settle in basements. That's why when we do sampling, we do it in basements. It's one of the reasons why like cracks in your basement should get addressed, because it allows for a really easy permeation layer to get into your basements. So if you have cracks in your basements, that's one of those things that you should actually address.
Thank you. And then the related issue is where people sleep, because a lot of people, those people who sleep in the lowest level of the basement obviously have much higher exposure because of the cumulative effect. And I was going to mention that most people probably don't know this, but a good chunk, if not the original studies, were done in the Rocky Mountain Center on radon. That was Vic Archer's work. And that's because of the uranium miners in Utah. And that's where the whole thing started really came to be known.
Yeah.
That's how that went.
I didn't know that, but thank you. Yeah. So with that, like it was noted that people sleep in basements, and in indoor winters, you spend the majority of your time. So like for that first column, you really wouldn't want to be choosing anything or making decisions based on any of the monitors that receive C grades. But once again, if there's any questions, so sorry about that. That was a big flub on my part. So thank you.